I was earlier a little bit surprised that 96% of the Michigan approach is mainly femoral, because nationwide, I think at Henry Ford, we're probably between 10 to 15% alternative access. So I'm not sure about those centers who have less, what they do for their alternative access. Talking about transcarotid, next slide. And I will try to be quick because I know for the sake of time, these are my disclosures. Next, I will mention that I'm really a proctor for transcarotid TAVR, and I'm really biased for that part. So transcarotid TAVR was first described in 2010 as alternative access for patients with iliofemoral or aortic anatomy that has issues in terms of atherosclerosis, small caliber calcification, or tortuosity. Next. For example, this patient with significant peripheral vascular disease and severe aortic valve stenosis, obviously transfemoral TAVR is not really a good option here, or not even a possibility. Next. Heavily calcified vessels, significant aortic disease, specifically in the arch, which I actually I have a strong opinion about, like the stroke rate in TAVR, transfemoral TAVR. I strongly believe that the main factor for that is the when we traverse through the arch, and that's probably one of the main reasons where we have strokes rather than the valve deployment. So going through the aortic arch is usually, I think, the main challenge for the stroke for those patients. Next. Also small caliber vessels, and I'm quoting here, Edward, I don't have the numbers for the other valves, mainly core valve, but if you're trying to put a Sabian of 20 to 26 millimeter and you need 14 French, you need at least 5.5 millimeter artery, and for 16 French, you need 6 millimeters. So if you have smaller arteries, the transfemoral approach is not really appropriate. Tortuous arteries, I added also this morbidly obese patient with large penis, where you have difficulty to get access to the groin and you have to do a lot of traction. I think the transcarotid approach and the neck approach can be very helpful. We also recently we have significant amount of Jehovah's Witness patients, and I think we automatically get them a transcarotid access if that's feasible, because you actually can definitely know how much blood loss you can do when you have a controlled access rather than bleeding in the retrograde in case you have a complication. So those patients who you cannot give blood, transcarotid access probably is really the best choice for them. Next. To do the only difference for those patients, it's the preoperative planning. They need a carotid ultrasound and the standard CTA to look at the neck arteries to be able to see the sizes and if there's any occlusion or any stenosis. Next. So the ultrasound, you look for the flow, carotid bifurcation, any stenosis, check on the vertebral artery flow, and also will help because if you are going to do transcarotid, you have to make sure that you'll be able to extend the neck and have some element of rotation for the neck. Otherwise, it's not going to be possible. Next. Right or left? And I know there's a lot of questions and debate and discussion about that. I personally think both are equally, can be equally used. I don't think tortuosity can be a problem. Sometimes in extreme tortuosity, yeah, you want to choose the other side if it's possible. A lot of operators like the left because of the claim that this is indirect in line with the aortic valve. I don't see a difference when doing that. I think one of the consideration when you want to do, it's definitely the size of the artery. If there is any calcification at the takeoff of the right of the innominate artery or the right carotid or left carotid. And also if you have stenosis, I think I will go with the site where you have more stenosis because you want to allow more blood flow to the brain for the contralateral side. Next. Again, I'm quoting this from Edward since the sizes for them. And I think the exclusion criteria, if you have a patient with small arteries or significantly calcified, Question about if the patient has a previous instrumentation or carotid endarterectomy or previous stroke. I don't think these are exclusion criteria, and transcarotid approach can be safely done with those. Technically, it might be a little bit more challenging with some adhesions, but I think it's doable. Next. So just have to pay attention to the stenosis of the arteries. Pay attention to the anatomic variants or congenital variants for the carotid bifurcation, previous surgery or stenting, contralateral carotid occlusion. And sometimes if you have contralateral occlusion and you have vertebral stenosis, artery stenosis, then you have to be careful and calculate your risk before you do that. Next. Question and debate about whether to do it in hybrid OR room or cath lab room. I personally think either one can be available as long as you adhere to the sterility techniques, and I think as long as you have the C-arm and you have the team, I think both rooms can be appropriate for both transcarotid TAVR. Next. Again, so I just put some pictures for the setup. I mean, it required a little bit of changes in the setup rather than transfemoral, because as Taib mentioned, the muscle memory, when you're doing the transfemoral here, you have to change the C-arm location, the surgeon, the assistant, and then the tables. Next. Same for left carotid. Next. Arterial axis, pigtail, you can radial or femoral can be done. If you have really bad femoral arteries, I think the radial is the best approach. Pacing through femoral, internal jugular, or through the LV confida wires is all possibility. The main key for those patients is cerebral perfusion, and I think bilateral cerebral oximetry is important, and to detect any changes in the perfusion in the brain. I don't think EEG is necessary. However, I know some surgeons are used to do some carotid endarterectomies and they like to use EEG. It's okay, but I think it's an overkill. I think the cerebral oximetry is enough. During the occlusion or during the deployment, and when you have the big sheath in the neck, I think we should have target blood pressure of above 140 or MAP above 90. Next. Technical consideration, I think that the carotid artery exposure, I definitely think it's much easier than doing transcaval. It's a quick incision in the neck, exposing the artery with 2 visual lobes and direct access under vision. You can access the common carotid artery. Next. I think this is one of the most critical and important steps is the sheath, because you have a significant amount of the sheath that will be outside the patient body. So care has to be taken to make sure this doesn't get out or slip deeper, and it can cause injury to the carotid artery, ascending aorta, or even the left ventricle. Next. In terms of the rest, the steps of the procedure, whether the choice of the valve, sizing, valve preparation, valve alignment, crossing the valve, and valve deployment, it's the same as transfemoral. Next. Then I think I have a video, but probably it was not sent there, but to show a deployment from the valve. But as I said, it's basically once you have the axis, it's exactly the same as transfemoral. The only difference, once the procedure is done, you try to minimize the amount of the big sheath in the carotid artery, deploy and come out. Primary closure, I personally like to do a small incision transversely in the carotid artery. It will give you a very nice repair at the end with interrupted sutures. I know some people like to do some purse string, which is okay. However, I think if you do a purse string, I recommend carotid angiogram at the end of the procedure to make sure you didn't have any constriction or stenosis at the site of the aortotomy, of the arteriotomy. Next. So as I said, these are the most important things for the transcarotid. Monitor the blood pressure, monitor for signs of stroke. Question of the anesthesia, I prefer to do it under general anesthesia. I'm not saying that it cannot be done with some local cervical block, specifically with certain people who are expert in carotid endarterectomy, and they do it under general anesthesia. That can be possible, but I think in the conduct of TAVR, I think general anesthesia is probably better. Next. The question here, what would be the optimal TAVR alternative access? And I think till now, I don't think we have any randomized prospective study to do that. I think the key will be if we can demonstrate in hospital and 1 year clinical outcome, stroke rate, change in quality of life, and cost of equivalence between all these alternative access. I think that's the key. Having said that, I am definitely not a fan of transaxillary access, and I think wherever I actually go and train, I try to convince people to switch from that to transcarotid. I think transcarotid is simple, easy to do, and easy to adopt, quick, and I think cost effective. And I do believe that the stroke rate for transcarotid, I know there are few studies there, but from our own experience at Henry Ford, I think the stroke rate is much less than transfemoral, and I think hopefully we'll demonstrate that in a study soon.